Welcome to the 2025 Hume Aged and Disability, Palliative Care and Aged Care Summit. This year we're going to be spending the whole day talking about dementia and palliative care. That is actually a topic that the people who came to last year's summit asked for. So if any of you came to last year's summit, you'll probably know what you're in for today. Hopefully a good time and lots of opportunity to speak to people who are experts in the field. If you haven't met us before, I'm Sam and this is Rose. We will just start with an acknowledgement of country before we talk you through what the day is going to look like and introduce you to Steve, who will be looking after us today.
Lush vineyards, ski fields and valleys of the Great Dividing Range and the mighty Murray River to the banks of the Goulburn, from Corryong to Yarrawonga, Mansfield to Seymour, we gather here in Wangaratta today. We would like to acknowledge the traditional custodians of the land, the Bangarang and Yorta Yorta peoples, and the Aboriginal peoples of the Hume region, whose rich cultural heritage and connection to this land have endured for thousands of years. We pay our respects to their elders, past, present and emerging, and recognise their ongoing contributions to our community. May we embrace reconciliation and work together with respect for the stories and traditions that shape this beautiful region.
Thank you. So yes, we would like to pay our respects to the elders, past and present, and anybody in the room today who identifies as Aboriginal Torres Strait Islander. You may notice a few things on your tables, of which one are bowls with little bits of fluff and scissors in them. Those are the 1,000 Hearts. I don't know if any of you have come across them before. If you are a tactile learner, we invite you to grab a couple of felt heart halves and stitch them together and stuff them with the stuffing. We hope that in honour of the 1,000 Hearts project, you make them with love and then you can gift them to somebody who you feel might need a little bit of love in their lives.
And
Go on.
if your table is missing some resources, just reach out to one of the tables near you. If you need an extra pair of scissors or some more thread, etc., etc.
Yes, yeah. You can negotiate with each other over colours of thread. There's a QR code here. Should you have any questions for the Q&A session at the end of the day, feel free to pop it in as it comes to you. It is open throughout the day. Should you come up with a question later and not be able to access the QR code, each of the table holders also has a copy of the QR code. So I invite you to go and say hi to the table holders if you haven't already, and they will show you how to put a question in, and I'll keep a track of that for you. And while you're there, have a chat with them about what they offer, take some stuff off them. If we can get the table holders to leave with not boots full of resources, that would be a great outcome for them as well. So take their stuff from them and bring them back to your facilities or where you're working. So Steve Pittman is a friend and colleague of ours. He is a palliative care nurse practitioner for the East Hume Consultancy Service. Steve has completed a Masters in Palliative Care, a Masters of Nurse Practitioner through Flinders University, and has over 20 years of experience working in palliative care. His special interests include aged care, communication, and fostering practical wisdom in palliative care. Welcome, Steve.
Thank you. Yuradu Marang, Jermadilinja Badu, Bangarangja, Yorta Dagunda. I'm very, very happy to be sitting on Yorta and Bangarang country to welcome you here to the 3rd annual Palliative Care and Aged Care Summit. Yes, important day to celebrate the important role of aged care providers and disability care providers in providing care for our elders and those with disability with life-limiting illness. Sam and Rose have done it again. I think you're going to be in for a treat today. That's our sincere hope. We've got workshops, guest speakers, panel discussions, industry tables, organisational tables, networking. We've got the lot. So, and a song at the end. So, yes, enjoy yourselves. I'm a firm believer that everybody brings wisdom to the table. So, particularly with our panel discussion, with our workshops as well, to make sure that you interact, that you participate, and you bring that wisdom to the table. Just a couple of practical notes. Toilets through the glass doors there, and then towards your left, there's disability toilets in the first sort of alcove, and then the next one across, you'll see the toilets in the corridor. That's my left, not your left. The other thing too is, in the event of a fire, don't be like Stephen last weekend. I was at a gaming convention at the exhibition centre in Melbourne, and they had to evacuate 80,000 people out of the exhibition centre, and there was all this, sort of bottlenecking of the doors and so forth, and people running everywhere. You'll be pleased to know, though, that there was a lot of people in cosplay too. So, I said to my friend next to me, it's okay, we're safe, we're surrounded by superheroes. We don't have any superheroes here today, well, of course, except for our aged care superheroes. But if they're in the event of a fire, just a very orderly walk through the glass doors there, turning left again, and then there's a door that goes out to the car park, and that's the assembly area in case of a fire. Kat and Chris from Northeast Funerals, up the back there, they've kindly offered to video and stream the day for us and for our online participants. During brunch, Sam and Rose will be roaming about with them to chat about your thoughts on the topics for today. If you do not wish to be recorded, please let them know. There is a waiver form where you registered, and you will find a sticker you can put on your badge to let us know not to approach you. But yeah, feel free to let them know at the time as well too. But according to Sam, if you play your cards right and treat them well, you may be able to wangle a discount on your prepaid funeral, quite possibly. Our industry tables over towards the left there, make sure you explore them, talk to them. I'm deliberately not going to say too much about them because it'll just give you an excuse to go up there and say, yeah, what's this all about? But we've got Palliative Care Victoria, the Palliative Care Advice Service, Murray PHN, Pepper and Pepper Aged Care, Advanced Care Planning Link Nurse, PayCop, Dementia Australia, Wicking Dementia, LGBTQI plus health. Make sure you go up and have conversations. You might even be able to get a few freebies from their table as well too. And as Sam and Rose said, make sure they can leave with the empty bags at the end of the day. So let's kick off. I would like to introduce our keynote speaker today. So Dr. Aaron Wong. Aaron is a dual qualified consultant geriatrician and palliative medicine physician, and is clinical director of supportive and palliative care at Eastern Health. He has previously held leadership roles as the medical lead for RMH, so that's Royal Melbourne Hospital, Residential In-Reach Service, Rapid Assist Palliative Care Service, Palliative Care at Home program, and the Austin Palliative Care Outpatient Service. He has an honorary appointment at the Royal Melbourne Hospital and is an honorary clinical senior lecturer with the Department of Medicine at University of Melbourne and Monash University. Aaron is passionate about holistic, compassionate care of older people and optimising quality of life across the continuum of illness. He has a keen interest in improving the quality of palliative care in aged care, interdisciplinary education, and has led several collaborative geriatric palliative care quality improvement projects at a local and health service partnership level. His research and education interests include dementia care, delirium, frailty, polypharmacy, and quality use of medicines, multimorbidity, models of care, supportive care and advanced illness, cancer, pain, symptom management, and end-of-life care. I think I'd like to talk to Aaron at the end of the day. I think too, him and Rose and I need to get together and form a palliative care band, I think, because it says here, outside of medicine, he enjoys watching movies, playing the guitar and drums, travelling and trying out new food places with his wife and 2 daughters. It is my absolute pleasure to introduce you to Dr. Aaron Wong.
Well, good morning, everyone. I'm really glad to be here and really excited. Are you excited for today? Yes. Fantastic. In fact, I'm so excited because I traveled 9,000 kilometers in the last 24 hours to be here with all of you today. I've been spending the last few days in Seoul listening to all the updates in the world of neurology and dementia. And so I've cut the conference one day short to be with all of you here today because I'm so excited to be talking about this very important topic. So I'll be talking today, and thank you for the kind invitation for me to be here today to present to you something that's really dear to my heart and something I'm really passionate about. A lot of these slides are a reflection over the course of my career with working with various clinicians, including aged care workers, palliative care clinicians, but even more importantly with caregivers and people living with dementia. There's so much to learn from them, much more than what we would learn otherwise from textbooks. So I updated the slides last night because I had to show you how beautiful Korea is this time of year. It's turning autumn leaf colors at the moment, and so it's been quite a beautiful journey along with some rain along the way as well. And I'd like to acknowledge the traditional owners on the land on which we meet today. The Bungarang and Yota people of the Hume region, as well as any Aboriginal and Torres Strait Islanders here today and present online. I want to start by saying that some of the slides are from a mentor that I've worked with over the years, Professor Dina Lojudice. Some of you might know her, who's done a lot of research in the field of dementia among Aboriginal dementia. They are inspiring caregivers who have trusted me with their care and sharing their journeys, stories, and experiences, and the care teams that I've worked with over the years. Okay, so this was a picture taken on a hike I went on this mountain called Seorak-san in Korea. It's a very confronting picture because there's so much going on, and it can be very overwhelming just standing there on the bridge looking at all of this. But when I stood there for a few minutes, I realized that there was something else in this picture. I'm not sure if any of you can appreciate that when you look carefully, there's a small deer who's trying to find food near the side of the rocky formation over there. And it reminded me that sometimes it's easy to miss the person when you're facing the complexity of the condition or disease that you're trying to manage and support. And it's very similar when you're thinking about dementia, that we often can miss the person when we think about dementia. And I want to emphasize that because it's actually the person that should and always remain at the heart of our care. And despite how overwhelming dementia is, that we should never lose sight of the person. We'll be talking today a lot about dementia, disability, deterioration, and death. But it's important to remind ourselves that aging is not just about getting older and frailer. Older age is a time of immense accumulation of wisdom and experience, growth, transformation, celebrating the connections, relationships, a time of reflection in which life, despite all its twists and turns, turmoil and triumphs, of hardship, heartbreak, and happiness, can still instill a sense of pride and fulfillment. Palliative care is not just about dying. Yes, while it recognizes that dying is an inevitable part of life, it is also life-affirming, living as well as we fully, as comfortably as can be, even when faced with significant health adversity. I'm going to read you, this was published in the New England Journal of Medicine by a physician called David Pisetsky. And he wrote a story about how he looked after his wife in the dying stages of dementia. His wife is called Ingrid. And he said, if my wife Ingrid could have chosen to be spared of any disease, it would have been dementia. She knew how it can distort and destroy a person, especially one as intelligent as she was. But Ingrid was not spared. She died of Alzheimer's disease in 2024 at the age of 79. Ingrid and I had been together for more than 55 years, having met in medical school at a time when few women became physicians. Generous, perceptive, and kind, Ingrid became an esteemed psychoanalyst as well as a wonderful wife and mother. But dementia left her deprived of words, unable to recognize her children, and unaware that her dream of being a grandmother had been fulfilled. Somehow she remembered me until the end. Perhaps because I was with her every day, making small talk, taking her on walks and cooking food full of umami, until one day she stopped eating and drinking, and I knew the end was near. Many obituaries say that deceased died after a long battle or courageous struggle, but such characterizations don't apply to Alzheimer's disease. Once the diagnosis is made, the battle is just about over. The patient's courage and resilience vanishing along the rest of their personality. The person with dementia is often unaware of the cascading troubles and may become furious when they're told, for example, that they can no longer drive. If the car keys are involuntarily surrendered, they may need to be forcibly snatched. The strife can be horrible. If there's any courageous struggle with this disease, it may be waged by the caregiver. So I want to pepper this talk with some of David's reflections along the way and just describe to you what a journey looks like, and acknowledging that the journey looks very different for someone, each person living with dementia and their family and caregiver. So this is the outline of my talk today. I'll be talking about the burden and impact of dementia, and I explain to you why dementia is a complex disease with multidimensional impacts. And then we'll move to talk about the value of palliative care, what supports and management approaches there are, and some final thoughts about the importance of integrating palliative care in dementia care. So globally, dementia is the 7th leading cause of death and a major cause of disability and dependency. As of a few weeks ago, you might have heard that dementia is now the leading cause of death in Australia. And this is not a surprise. I thought it would come up in the next couple of years, but it's come up actually in the last few weeks when they analyzed the data from last year that it's overtaken cardiovascular disease as the leading cause of death. We know that 2/3 of people with dementia live in the community, and about 433,000 people are thought to live with dementia in Australia. And I think that's an underestimate of the true number of people living with dementia, because many go undiagnosed and under-recognized. In residential aged care, well more than half of people have moderate to severe cognitive impairment. Notice how I said cognitive impairment and not dementia, because many are still under-recognized and undiagnosed. And it's very costly, more than 3 billion, and this does not include all the uncalculated costs of caregivers giving up their work, their careers to look after someone living with dementia. And it's also responsible for numerous hospitalizations, many of which I will show you over the next few slides that are potentially avoidable and unwanted. Dementia is a very complex disease with multidimensional impacts. And I want to highlight that it is a very complex disease because dementia used to be a condition where a lot of people had attitudes around dementia where perceptions of age and being ageist or nihilistic attitudes often prevail, and to some extent that still holds true. But the times are changing and dementia is coming back into the spotlight again. But I want to highlight in these few slides that it's not just a condition that is like heart failure or kidney failure or cancer. It touches multiple aspects of a person's life. And this is taken from the Lancet Commission, where it highlights that people with dementia should have access to palliative care as the remainder of the population. But my question to you is access to palliative care in dementia equitable? If you think about the people we look after and serve, people with cancer or other conditions, do we think that access is similar? And I would argue it probably isn't. People with dementia experience significant symptom burden, such as pain and breathing difficulties, in fact similar to patients with cancer. But they are less likely to receive palliative care and face many barriers to access. And this often results in inadequate management of their symptoms, especially at the end of life, even though we know that palliative care is a beneficial approach to improve the quality of life of people with dementia and their caregivers. You might have seen or read the Australian Cancer Plan that was released not too long ago, and that's the Victorian Cancer Plan, which highlights the importance of having access to early integrated palliative care. And this was recently released as well, the National Dementia Action Plan over the next 10 years. Palliative care is mentioned 50 times in that document, and I'll highlight the areas in which they highlight palliative care being important there. And the clinical practice guidelines in dementia is being revised at the moment as well by Monash University. And as you know, the support at homes coming up on the 1st of November with all its changes and trepidations across the sector about how that's going to look like. So there's lots of changes in the field of aged care and dementia care as well. And I think I highlight that as well because there's lots to learn from the cancer care model, where someone comes through and gets diagnosed, goes through a multidisciplinary discussion, and cancer care gets a bit more navigation than a lot of the other conditions as to supporting the journey ahead. But dementia really lags behind in terms of the support once someone gets diagnosed, if they get diagnosed. So the National Dementia Action Plan highlights the importance of having better pathways and options, the importance of having culturally appropriate care, the value of having advanced care planning, especially earlier on in their disease, the importance of quality of life needs and preferences, be that physical, psychosocial, and spiritual, and the priorities of having comfort and dignity throughout dementia care. And really what's important as well, and I hear this from a lot of families supporting loved ones with dementia, is the continuity and coordination of care in the face of very fragmented care, as you will all experience and are well aware of. And the real importance of caregivers in that journey as well. Okay, so for this slide, I'd like you all to stand up and do a bit of stretching, because after attending 3 days of conference in Korea, one thing that struck me about conferences is it's very sedentary and you sit there for long hours during the day. So I'm going to talk to this slide while you stretch a bit. Up to 45% of dementia can be prevented. And I think one of the very important take-home messages is that we all need to be brain health advocates, because prevention of dementia starts in midlife. And lots of factors such as education, managing hearing loss, cholesterol, diabetes, being physically active and exercising, not smoking, managing blood pressure, are all absolutely crucial in reducing the risk of dementia. And it's been shown time and time again that when these factors are addressed earlier on in life, from midlife onwards, that the risk of dementia can be reduced, and indeed dementia can be delayed, which is really very important. So we can't emphasize this enough about trying to reduce the risk of dementia. All right, okay, I'll get you to sit down. Back to our sedentary lifestyles again. But really important, because a lot of people after talks I give often ask, can dementia be prevented? And yes, the answer is it can be prevented. So I thought for us to think about palliative care in dementia, it's really important for us to understand dementia and what someone goes through from diagnosis. The first point I want to make is dementia is complex because it is not just one condition. As you know, there are many types of dementia, and dementia really is a term to describe a clinical syndrome where someone has memory or cognitive problems that might also manifest as mood and behavioral problems, and that starts to interfere with your day-to-day activities. Alzheimer's is the most common, as you can see there on the left. About 60 to 70% of people with dementia have Alzheimer's. But there are other conditions as well, such as vascular dementia, Lewy body dementia, the less often heard, but actually the second most common neurodegenerative form of dementia. Frontotemporal dementia, where they can often have very marked speech difficulties or behavioral disturbances. And you might remember some of the one of the celebrities, Bruce Willis, was diagnosed with frontotemporal dementia, which they describe as a language variant, which is a semantic form of dementia. So you can see there that dementia is not a single specific disease. There are many types of dementia with symptoms that do often overlap. The second point I want to make is that people with dementia often don't just have dementia. In fact, only 17% of people with dementia just have dementia. They have other conditions such as heart problems, kidney diseases, cancers, strokes, and so forth. And so a lot of people living with dementia have got comorbidities, and that becomes very important as we care for them because different conditions affect dementia, and dementia also affects the other conditions and how we manage them and how their symptoms manifest as well. And the other thing I want to emphasize is dementia is not just a memory or cognitive problem. We know that other problems arise in dementia, such as seizures, falls, dizziness, incontinence, swallowing issues, frailty, nutritional problems, oral health problems, delirium, pain, polypharmacy, and so forth. So dementia is so much more than just a cognitive and memory problem. And indeed, the people I've been looking after over the years, we see this in different parts of their journey, and managing it and monitoring for the emergence of these is really important as well, both in the home and residential aged care setting. So I want to take you back to the start, acknowledging that everybody's journey is unique and can be different, but it's important for us to understand the disease, the person living with dementia, and the family caregivers supporting the person as well. Unfortunately, in Australia, there's still about a 3 to 3.5 year delay for someone to presenting with symptoms to get diagnosed with dementia. And so there's delays to getting diagnosis with many barriers, such as people thinking that memory problems might be due to old age, the issues of having not enough access to doctors, specialists to diagnose dementia, and there may be rural regional disparities in that, and socioeconomic disparities in that. So many go undiagnosed. But most people presenting with memory complaints present to GPs as a start. Some of them get picked up in hospitals by specialists and memory clinics that some of you might have seen people with dementia get diagnosed. But there's a whole different range of avenues where people might be picked up and diagnosed with dementia. They usually present with symptoms of memory problems, some forgetfulness, some slowing of thinking, some personality or mood changes, or behavioral changes. And when they're in the GP practice or the specialist clinic, they receive an assessment, they get a story from the family or their support person about what changes have happened over the last months or years. They undergo a cognitive assessment and they have a physical examination. They often get blood tests to rule out other conditions that might interfere with memory. Nowadays, everyone virtually gets an imaging of their brain, usually a CT scan, but these days MRIs and PET scans as well. And very interestingly, dementia, as you would all be familiar, used to be diagnosed clinically. So when you've got a person's story plus examination and you're ruling out other things and looking at their brain scan, collectively you put a picture together about dementia. But as of a year or two ago, we now are in this new era of biomarkers where very excitingly, with special scans and special blood tests, which will soon be at our doorstep, we can diagnose Alzheimer's dementia with the appropriate history and a blood test, which is incredibly exciting because early access to diagnosis offers a lot of timely benefits for planning, for supporting the person, and even access to new therapies, as some of you might have heard in the field of Alzheimer's. The journey isn't straightforward though, as you know, dementia is a complex problem. It also comes with navigational challenges as well, navigating the whole myriad of support options from diagnosis. So it's about education, linking in people with the appropriate supports and care, multidisciplinary coordination, managing various symptoms, navigating my aged care, linking in with Dementia Australia, and Dementia Support Australia when behaviours emerge, advanced care planning, and palliative care as well. So lots to think about, and you can imagine the first appointment's often very overwhelming for the person with dementia and their caregiver. So often at times in a memory clinic, someone would spend time with the person with dementia, and then they come together in a case conference to have a chat about the implications for dementia on driving and the post-diagnostic supports. It's a bit hard in private. I try and break it up into 2 appointments. Often at times it's very overwhelming to receive not just the diagnosis of dementia, but to talk about all the steps ahead. So I think it's really important to be thinking about how that can be done in a coordinated way, but also in a staged way as well. So I put this slide in because it is a maze to us. It is more of a maze to people living with dementia and their caregivers. Sadly, this hasn't really improved all that much. You look up the websites, there's just so much going on and so many services, not just in the hospital, but in the community setting. And it can be really frustrating for carers to think about how they can link in and support someone living with dementia as well. And so there's a lot of work that needs to be done to integrate, to coordinate these services better, and to ensure that these services are more timely and responsive. I'll name a few, and we do have some of these organizations and services here today. So Dementia Australia, remarkable organization providing education and support for people with dementia. They have got a number that people can call on to talk through dementia. They've got support areas as well, support groups that people can tap into. Dementia Support Australia does a fantastic job in supporting people with behaviours, management strategies, both in the home and residential aged care setting. Lots of education and support through them as well. My aged care probably don't need to mention so much, but they're the gateway for providing home and aged care services along with residential aged care approvals as well. Advanced care planning, really crucial and can be done well earlier on when someone does have capacity through their family, caregiver or support person. And it's really important to capture that earlier on to allow appropriate planning and goal-aligned care as they progress with their condition. Carers Gateway is also a very useful resource. And some of the other options there you might or might not have heard of. Forward with Dementia was a resource developed by alongside people living with dementia and their caregivers. There's an app called My Dementia Companion, which can be paid through their home care package as well. And I often point people in these 10 questions to ask, especially when people are thinking about entering residential aged care. They often ask me, what do we ask when we arrive in residential aged care home, about palliative care, about the lifestyle activities, or what the home is like and what they can offer. The aged care guide as well is helpful to point in the right direction in terms of services locally, but also residential aged care homes as well. But I put there, and very importantly, is a lot of people, when I see them, ask me, is there an opportunity to participate in research? And I don't bring it up with them. I do bring up with them with time and for people that might be eligible, but surprisingly, a lot of people ask me off the bat, is there any opportunity to participate in research? And Dementia Australia has a page where people can look up for various clinical trials and research that's happening. But there's an organization called AdNet as well, which I refer people to, that have got various trials, and I'll talk a bit more about some of the trials that are happening, which is very helpful in supporting people living with dementia to access novel therapies and support options, but also access treatments that they wouldn't be able to access otherwise. There are challenges, though, in terms of care across the journey. We know I mentioned diagnostic delays, barriers in support. We know that an older person faces other challenges as well, such as falls, incontinence, and delirium. Prognostication is difficult, and I'll talk more about this shortly. There's a huge caregiver burden and stress across the journey, not less contributed by the frustrating experience of navigating care pathways. Behavioral and psychological symptoms of dementia is a big issue as well, and that can emerge and wane and come up again from time to time. Capacity loss is an impactful state that can affect various decisions around healthcare, but access to services and where someone lives. The challenging of assessing and managing symptoms when someone's not able to communicate that. Medications are tricky to manage as well, and they are more susceptible to adverse effects from medications too, and the risk of hospitalization and coordination of care, as I mentioned too. Now, that might all sound very depressing, but I do want to highlight that we are in a very exciting era for dementia, and it's now come into the spotlight not just from the fact that dementia is now the leading cause of death in Australia, but also because for many, many years, dementia research has been very depressing in that all the therapies that have been thrown, all the money that's been thrown into dementia treatment has been very disappointing. But in the last few years, we've seen some new therapies that remove amyloid from the brain of people with Alzheimer's disease, and amyloid is the abnormal protein that causes Alzheimer's in people's brains, being shown to not just be effective in clearing amyloid from the brains of people with Alzheimer's disease, but it's also slowed the disease process right now by about 5 months, which is very impressive given that there's been no breakthrough up until today. Now, you might think 5 months might not be much, but remembering that this is the tip of the iceberg where these treatments will continue to get better, much like cancer therapies as we once knew. And in fact, cancer therapies, if you think about it, do prolong life maybe in 3 to 5 months, and some a bit longer depending on their condition as well. But with dementia therapies, these only work in the earlier stages of dementia, so it's absolutely imperative that people get access to timely diagnosis to receive the appropriate treatment and care as well. And this is an article published by some colleagues to highlight that the infrastructure of dementia diagnosis and care in Australia really is not up to the standard we hope it could be to support people receiving appropriate and timely treatment. And this disparities is even wider on a global scale if you think about low and medium income countries as well. So there's advances in the field of dementia, and it's a very exciting time to be in the dementia space because we can diagnose dementia more accurately with not just imaging, but blood tests are at the horizon. In fact, I received my first blood test results for a patient 2 weeks ago, which is very exciting, through a clinical trial. And it helps people, it gives people closure when you're able to demonstrate that, yes, we've got very high certainty that we're dealing with Alzheimer's disease, and you can educate people about what the journey looks like. As you know, various dementias have got different patterns of deterioration, different symptoms that might emerge. So it's very important to be able to give people a very accurate diagnosis of what type of dementia they have. And along with that, with Alzheimer's at least, there are now disease-modifying treatments on the horizon, 2 of which have been TGA approved, but unfortunately not approved by the PBS for subsidy. So they cost people around $80,000 to $100,000 now to receive them out of pocket, but are still accessible through clinical trials at this stage. And it's the role of technology in supporting people through remote monitoring, behavioral psychological symptoms of dementia, artificial intelligence, which leaves no area of medicine and healthcare untouched at the moment, and the models of care that we need to think about to make care less fragmented and to make care more accessible. So, having said all that, I think it's important to think about what dementia trajectory and progression looks like. David goes on to say, the progression of Ingrid's illness was relentless, and changes came in jolts and spasms. There was no lingering farewell. Ingrid needed me to be present and immediately available to help and calm her during the terrors of her final days, which took all my strength. Still, I loved her greatly and felt comforted by her presence, knowing that the next change would be the most devastating, life without her. And so we come to the question of, how do people deteriorate with the progression of dementia? There are some features that are quite common that people experience nearing the end of life, such as not eating and drinking as much, losing weight, having swallowing difficulties, becoming more bedbound, not being able to communicate, being more dependent on others, and becoming frailer. We also know with dementia that mood problems can often occur at the earlier stages of dementia, and in fact, even at the phase before people develop dementia, they may go through periods of depression. And then cognitive function deteriorates over time. Behavioral symptoms tend to happen in clusters, so you might get waves of different types of behaviors, and then that wanes over time. I mention that because it's important, because sometimes we're not quite sure whether occasionally when we use medications to treat distressing symptoms related to dementia, whether that's actually doing much of a difference, or whether it's actually the behaviors, waning over time itself. But by and large, what's responsible for a lot of the care around behaviors is a person's environment and the care, and how the caregiver adapts to the person's changes. And I find this time and time again, families telling me that it's such a journey, and they learn just as much in terms of adapting their behaviors and approaches and responses when someone changes over time with dementia. This is taken from the Lancet Commission for Palliative Care in 2018. You can see that at the bottom right graphs that you would often see in trajectories. So as you know, with cancer, you can often get ups and downs because of people getting chemotherapy, immunotherapy, and people can get very sick and then end up in hospital, and then things get better as your cancer comes under control and under remission. And in the last 3 to 6 months of life, people decline very rapidly. Heart and lung failure, people often get exacerbations, and they get very sick when they have fluid overload, or they get lung exacerbations. They may or may not end up in hospital, and overall they deteriorate over time. Frailty and dementia is often described as that very low function, dwindling, gradual pattern down there, but I think it's an oversimplification. And the reason for that is, firstly, as you can see there, the graph down there represents different types of dementia. Alzheimer's tends to be more gradual. Lewy body and vascular tend to be a little bit up and down over time. And the other thing to mention is people with dementia, especially when they're over 80 years old, they don't just have one type of dementia. They often have mixed disease. They often have Alzheimer's and vascular dementia. It's probably the most common combination. But they can have Lewy body and Alzheimer's dementia, and that can look very complicated. And if I take you back to a few slides, you might remember I said people with dementia don't often just have dementia. They've got other conditions as well. And so it can be quite hard to determine which is the dominant trajectory when you're thinking about someone living with dementia. And it can often be very difficult to prognosticate. On top of that, we know that someone with dementia may not just decline in a very linear, gradual fashion. They might have a fall and break their hip and end up in hospital. And then they have a delirium, and they might not be able to return home when they enter residential aged care, where they might have other infections and get delirium, more falls, aspiration pneumonia, and then they die. And so that trajectory can often be gradual but punctuated by acute episodes of deterioration and illness. And that's the one that's hard to predict, because someone might be stable with dementia for some months, but in the last 3 to 6 months of life, you might see very sharp dips in function. And as they get frailer, they don't quite get back to what they used to be. They recover somewhat, but they get physically and cognitively more impaired as well. So I find it very helpful when I draw out these graphs for someone with dementia and your caregivers, when I see them in residential aged care or in my rooms. It helps them to plan for their journey ahead, to think about scenarios that might occur as their dementia progresses as well. So that's why dementia is so complex to prognosticate. And I must say, even as a geriatrician and palliative care physician, when I ask to see someone in hospital to think about whether they should come to the palliative care unit, it's immensely challenging to work out where they are. But it's really important to educate families and caregivers, in fact, other colleagues as well, about what this might look like. Because one of these dips might be a dip that they would not recover from. This was an article published a few months ago, which a lot of families asked me at the first contact when I provide them a diagnosis. How long does mum have before she ends up in a nursing home? What does the journey ahead looks like? Now, I must say this is a population level, so the individual person might vary. But usually, because of the delay to diagnosis, the median survival is about 5 years from diagnosis. That may range anywhere from 3 years to 10 years to 12 years, depending on when and how someone is. Usually a third of the remaining life expectancy is lived out in residential aged care. More than half move to residential aged care within 5 years after a dementia diagnosis. The most common reasons of which are incontinence, nighttime behaviors, and increased dependency on care. And the median time is usually around 3 years for someone to end up in residential aged care, although that might vary with someone's age, sex, clinical characteristics as well. So it gives you a guide, and probably holds true if you think about how people progress with dementia. And I must say, in my experience, hospitalizations are a very rapid catalyst in someone's decline, which is why, where possible, I tell people, if we can keep you as well as possible living at home, that's going to be the best way of trying to keep the deterioration as gradual as possible, because when someone enters hospital, they decline very quickly, and they don't quite recover to what they were before. And why, you might ask? Hospitals are a dangerous place. They promote environments that are not routine and familiar for people, even without dementia. Delirium is very bad for the brain. Medications can often give more side effects than benefits. People do things to people in hospitals when they don't like it and don't want it. So goal-aligned care is a real problem in hospitals, and we should be thinking about how we can improve that. But also, I think it's very important to recognize that hospitals are not very dementia-friendly places to be in. And so it can be a very distressing experience and frustrating experience for someone living with dementia and your caregivers as well. Now, that said, hospital does have a role and can be important when someone's very ill. But in general, if we can avoid people landing in hospital, that's really important. And one of the ways is through vaccinations. Some of the ways would be to improve the models of care we have, in such as hospital in the home. We can provide care in the home where that's safe and appropriate. So there are ways to think about how we can care for someone with dementia. And I talk about these scenarios when I see people over time as well. It gives people options to think about. And in residential aged care, that's similar. You might have services that might be able to reach out to people living in aged care homes to deliver acute treatments, but also to deliver palliative care there as well where needed too. So if we can avoid unwanted and avoidable hospitalizations, that's often very helpful. So living and dying with advanced dementia can be accompanied by distressing symptoms, such as pain and agitation, aspiration, shortness of breath, infections. About a quarter do not resuscitate orders. Less than 40% have advanced care plans. There are high rates of hospitalizations and healthcare utilizations, as well as ED presentations as well, and caregiver distress. And we know that there are many clinical issues that can occur in end-stage dementia, such as delirium, behavioral and psychological symptoms and mood changes, immobility and falls, incontinence, adverse treatments and effects from medications, including palliative care medications, which can often be very challenging as we think about the common medications that we show you why in a moment. And they've got lots of pills that they take anyway, and some of these pills can contribute to more problems such as anticholinergic side effects such as falls and delirium, dry mouth and so forth. So this is a slide I put together just reflecting on the benefits but also the burdens and dangers of the medications we use in palliative care. We know that opioids can provide relief in pain and shortness of breath, but they can often be accompanied by drowsiness, delirium, constipation, nausea, and falls. So I must say, as often as I prescribe opioids to people living with dementia at various stages, I often de-prescribe them as well. And that includes a buprenorphine patch. I prescribe just as much as I de-prescribe them in hospital and in clinic as well. Constipation, giving laxatives to someone might result in dehydration, falls, and incontinence. Antiemetics such as metoclopramide, Maxilon might help with nausea, but might give them signs of Parkinsonism, dizziness, drowsiness, and medications like ondansetron can be very constipating for an older person too, and a younger person as well. Steroids that we often use in cancer-related symptoms can cause a whole host of problems in people who are older and with dementia, delirium, sleep disturbance, and so forth, as you can see there. And benzodiazepines that we often see used in palliative care might help with anxiety or severe agitation or sleep problems, might result in further cognitive decline, delirium, and falls. In fact, there was a study published this morning that showed that benzodiazepine antipsychotics used in people with dementia who are referred to hospice resulted in much higher mortality compared to people who weren't prescribed that. And so we need to think carefully about the benefits and burdens. And one of the studies published about delirium that some of you might have read by Mira Aga showed that people who receive antipsychotics for delirium in the palliative care unit did not benefit symptoms but actually caused them to die quicker. So it really makes us think about what role, if any, when we use these medications, and we have to use them cautiously. That's not to say they don't have a role. In terminal symptoms, as I'll demonstrate to you in a few slides' time, these medications are absolutely crucial in keeping someone comfortable in the last hours to days of life. So really, there are a few themes that are recurring, as you can see in the slides that I've shown you. The importance of timely diagnosis, advanced care planning, legal aspects, transitions in care, delirium, nutrition feeding, medication reviews, psychosocial support, end-of-life care, and grief and bereavement, which I want to highlight that grief as you all know, doesn't start when someone dies. It often starts when a diagnosis is provided to someone. And there's two types of grief that we often experience before someone dies. One type called anticipatory grief, which is future-oriented, and where someone worries about a future without the person with the illness being present. And illness-related grief, which is where an illness erodes and causes the loss of personhood, a role, identity, function of the person, and how that chips away at and causes grief as well as the disease progresses. And when you look at the palliative care literature, there are 11 areas, at least 11 areas that are relevant for palliative care, which are highlighted on this slide as well, and which I've touched on the previous slide. And what's important for good palliative care is that it needs to be multidisciplinary across the care journey. Goals of care is not a once done, set and forget situation. It's a constantly revisiting this at transitions of care and when navigating treatment and care decisions. But early planning is absolutely crucial, and support needs to be holistic. This is a slide about what palliative care resources and supports are available out there. The ANAC Class 1, which is the palliative care status form for someone entering residential care for palliative care. The end-of-life pathway, which is starting on the 1st of November. The Palliative Care Advice Service, which does an absolutely wonderful job in providing support across the state. 7 days a week, and I know Esther's trying to make it 24 hours. Absolutely valuable for people living and supporting someone with dementia. Community palliative care, which is geographically based and located. Victorian Virtual Emergency Department, InReach, Rapid Assist, and a whole host of other resources, including the Bertie video, which I didn't show earlier, but encouraged to have a look at. So the Bertie module is a very nice education module, which is very punchy, concise, which you're like me, attention span short. That's a very valuable resource for education. And I was asked to help out with the palliative care section of the Bertie education. Okay, so this is a question that was often asked in various forums. When should someone with dementia be referred to specialist palliative care? So I was asked to be on this international Delphi consensus group published by Catherine Chang and Jenny Phillips group when they looked at this. And this international expert group came up with 15 major criteria, which does not surprise you at all. The figures are a bit small there on the right side, but they are around needs, symptom distress, and you can see those there, psychosocial factors. It can also be disease-based, such as rapidly progressive forms of dementia, comorbidities, where they might have, example, at least 2 episodes of aspiration pneumonia in the last 12 months. Hospital use is an important one too, whether they had an intensive care mission in the last 3 months, recurrent emergency or hospitalization visits in the last 3 months or so. And so the question that often arises from qualitative studies from family and caregivers are the perception around when dementia is at an advanced or severe stage. Is hospice or palliative care specialist, palliative care the right choice? What are the practical aspects of supporting caregiver stress and burden, and the emotions and perceptions around death and hospice care, and guidance and access to palliative care services as well. In the next few slides, I do want to take you through some of the common symptoms and issues that occur in dementia. And there may well be more as you've come across, but I've put there some of the more common ones that I've encountered and people have asked me about over the years. And so these are just a start to think about some of the principles that go through my mind, and hopefully there might be some helpful tips there as you look after people living with dementia and support your caregivers as well. So we'll go through pain first up. Pain occurs probably in about at least half of people who have cognitive impairment, and so it's often under-recognized and under-treated. It impacts on people's mood and behaviors and often manifests as what we see as agitation written in the notes. How might we assess pain in someone who's not able to communicate? So there are various scales that can be used, such as ABBYS and Pain AD. And these look at signs, non-verbal behavioral signs that might give us clue to whether someone has pain. The other thing that I often find helpful is to ask, what conditions does this person have that might give rise to pain? For example, they might have very bad osteoarthritis, they might have a very deep pressure area, or they might have other conditions like cancer that might be causing pain. So what's the likelihood of someone having pain at the baseline? More interestingly, and this is an Australian company that had developed this proprietary pain artificial intelligence product that some of you might come across called Pain Check. So this marries some of the tools alongside with a facial analysis scan to analyze very minute and micro expressions on the face to see whether someone has got pain. I believe Pain Check has worked together with Dementia Australia, and this has been very well validated in the residential aged care cohort. And indeed, I think PayCorp has incorporated that into their pain assessment as well. We just received a small grant from Pain Check to do a study in the palliative care unit setting, so we'll be doing that in the next few months, so this will be very exciting to do. The nurses on my ward are very exciting, scanning each other's faces to have a little practice of what the Pain Check looks like. So I think it's very important to think about how we manage pain from a non-medication approaches, so massage, heat and cool packs, positioning equipment, stretching exercises, relaxation strategies. Topical therapies can often be helpful. Simple analgesics like paracetamol is often very useful as a trial to see if that might help. Sometimes we think about low-dose opioids in some patients, but always important to monitor and review whether that's helpful as well. And I think in someone with dementia who's older, we usually try one thing at one time with medications, and we start low and go slow. Occasionally, some people who might be suitable, we think about certain blocks for them, but that might be challenging someone with dementia when they're sitting still for a scan, and for a block might be tricky. So we think about that, just balancing them up and weighing up the options there. They might have a very stiff and painful shoulder that when we just inject it with a nerve block or some steroids, that might help alleviate the pain considerably. Eating and drinking problems is very common. As you know, nutrition and swallowing and losing weight is a very important physical, and not just physical, but a very important social and cultural issue as well. Being able to feed someone's important because that's an expression of love and care. So this is often very common at the end of life in someone with dementia. Appetite, taste, and food preference changes occurs when dementia progresses. And some forms of dementia, like frontotemporal dementia, can cause very marked food changes where someone might be lose their appetite altogether, or they might just change from someone who doesn't like sweet foods to just absolutely hunting down for every sweet food under the sun. And so that may be part of the dementia process. I think something that we don't do often, both in the hospital setting and in the communities, we don't look in people's mouth as often as we should. Simple problems like dentures that are not fitting, gum disease, ulcers, thrush, can often impair someone's ability to have food in a comfortable way. And dry mouth is so common, not just from the ventilation, but also from medications we give patients that cause dry mouth as well. So good mouth care is really important. Eating and drinking with acknowledged risk is also another very important area. So very important to discuss this with patients and their family caregivers about when someone has a texture-modified diet, but they don't find that palatable at all, but are at aspiration risk and having nutrition for comfort. And really the best practice is oral assisted feeding. And sometimes, questions come out around PEG tubes and tube feeding, which really hasn't been demonstrated to give much quality of life or indeed benefit people from a nutritional or mortality point of view as well. In fact, it can cause more problems with behaviors, PEG tube-related issues, and infections. Important to check for constipation, and also to think about other changes and whether eating and drinking problems actually might be a sign that someone's approaching the end of life, and having appropriate conversations about that. So there are various tools that can help with this, and this is one of them. This is taken from one of the journals and dementia, I think the dementia organization in UK, Marie Curie Institute. And so these are some of the helpful things that I might go through with some of the families that I see. Recurrent infections is also another common thing that people with dementia experience. I think the important thing is people with dementia may not have a fever or focal symptoms. All they may present with is a delirium. And so they might be a bit more confused, and so I educate families about delirium being potentially a sign that something's changed, whether that be new medications or an underlying infection. And so preventative strategies are important, such as making sure that your bladder and bowels are working as well as they could, fluid intake, addressing constipation, good mouth care, good skin care, and also very importantly, as infections occur more commonly towards the end of life, to have good conversation about goals of care, frailty, diminishing reserve, inability to respond to or improve from infections, trial of treatments, and indeed when someone tells you that these things are not aligned with your goals and preferences, that we respect that and capture that and document that, so that the next doctor or nurse that can't help themselves won't transfer them to a hospital or institute things against their wishes. Delirium is such a common thing in people with dementia, and it increases as dementia progresses towards the end of life. There are many common precipitants, as we're all well aware of, and it can be very distressing for patients and their family caregivers. And as frailty increases, the threshold at which people get delirium becomes lower, so it might not take very much for someone to get delirium when they're more frail. And it's really important to have good goals of care conversation when someone experiences delirium, because delirium is associated with higher mortality, but it also causes accelerated decline in dementia as well. And there's lots of things we can do to prevent delirium, and so good care prevents delirium. So making sure someone's hydrated, looking after bladder, bowels, making sure that people have access to sensory aids like the hearing aids, glasses, making sure the dentures are accessible. All those things are very important in preventing delirium, not just in the community, but in hospitals as well. Breathlessness actually surprisingly is quite common. So about a quarter of people experience breathlessness with dementia. And this might be due to comorbidities listed there. Breathlessness, there's lots of things you can do, such as posturing, breathing patterns, using a fan. Some of this might be more effective in earlier stages of dementia. Managing concurrent anxiety. Occasionally, the use of oxygen might be helpful for some patients if they find it beneficial and they can tolerate it. And some symptom relief medications at the end of life when people suffer from breathlessness. This is the big elephant in the room, I think, the behavioral and psychological symptoms of dementia. This is very challenging, and I think a lot of people feel very confronted, both in the home, residential aged care, and hospital setting, when someone with dementia experiences tricky behaviors, and that might range from constant wandering, pacing, to experiencing hallucinations and delusions, to being agitated, to having sleep challenges as well. But it's really important to communicate this with families earlier on, and to support them to identify what types of behaviors and impacts and safety concerns that it poses. Important to think about what unmet needs a person with dementia experiences, but is not able to communicate that. Pain is one of them as well. But the idea of having person-centered environmental modifications is really absolutely crucial, not just throughout, but even at the end of life as well, when someone exhibits behaviors and is experiencing distressing behaviors. Comfort and dignity, and it's really important to honor someone's identity and preserve dignity as much as we can, even though, imagine that picture I showed you earlier. It's so easy to get lost in that whole picture and lose sight of that that small deer in the picture and lose sight of the person experiencing dementia as well. There are medications we use for tricky and distressing behaviors. We use that very cautiously, and when behaviors pose significant harm or distress to a person. But it's also important to note that some behaviors do not get modified by these behaviors, such as wandering or calling out, vocalizations. Agitation when someone's dying in the last hours to days of life, we still need to ask ourselves, what unmet needs are we missing here? And it's really important that we can only identify this by knowing the person. And so it's very hard to do that if we don't have some history or support person to tell us about what are some of the signs that we can recognize that someone might be wanting to communicate to us about their needs. And so it's really important to try and understand that as much as we can from the family and caregivers, or from carers that have known them over a course of time. And so it's important to support some of these interventions and even review medications that might not be helpful. But severe behavioral symptoms are associated with higher mortality and considerable distress, not just on the family's part, but for caregivers looking after them as well. And this poses a lot of side of care challenges, where challenging behaviors are tricky to manage in the home, in residential aged care, in hospital, and in palliative care units. And so, where's the best place to look after these people is often very challenging and distressing for everyone involved. But the principles still hold, and I think it's really an interdisciplinary approach and a holistic approach to manage behaviors. Sleep's a really important thing. I know this because of traveling 9,000 kilometers in the last 24 hours. But sleep is so important for someone who has dementia. And sleep's often disrupted when you end up in hospitals, as some of you would know, because lots of things go beep and go bump in the middle of the night as well. But having good sleep hygiene, engaging some activity, having good sunlight exposure during the day with an open window, going out to the courtyard or the garden is really important. Reviewing medications that might upset the sleep-wake cycle, such as steroids or sedatives, and considering things that might affect people's sleep, such as pain, mood, going up to the toilet multiple times at night, breathlessness. And more recently, I've had a few people that had undiagnosed restless legs that actually was very hard to communicate from the person's point of view, but they just kept on wanting to get up from the bed in hospital. And when we realized that it was the causing side effect of one of the new antidepressants we had started someone on, we stopped there, and immediately the restless legs went away and they could sleep at night again. And to the clinician, that could mean, when you're seeing someone trying to get up at night, we might think that's delirium. We might think that that's someone dying because they're so restless at night. But it might not be as well. And so be very cautious about thinking whether we might be causing harm by something we're doing to them with medications or environmental changes. And there are various medications that can aid sleep when we've looked at some of these other factors as well. Falls is a big one, and the reason why a lot of people end up in residential aged care as well. And falls are due to factors that a person experiences, their environment, behaviors due to the dementia process. It's important to review medication and think about whether we're causing more problems by dropping your blood pressure, vision, footwear, dizziness, imbalance, thinking about AIDS, falls prevention strategies, and to think about looking after bone health, especially when people have a longer life expectancy. Usually, by that I mean more than 12 months. As you know, having a hip fracture is often a catalyst for someone deteriorating very rapidly. And in fact, the mortality from a hip fracture in someone with dementia is somewhere in the order of 25 to 30% in 6 months. Incontinence can be urine or bowels, and so we think about aids and equipment, reviewing medications that might cause these, considering prostate issues or prolapse issues. Are they in retention? Have they got edema in the legs that are contributing to nocturia, getting up at night to go to the toilet? Good hygiene care, thinking about prompted voiding, and a role for medications targeting specific conditions as well. This is another crucial aspect in dementia care, which is decision making. And I talked about advanced care planning and goals of care. Really important to understand someone's values, preferences, and goals. To think about how they can be supported in their decision making. I think this idea of supported decision making is absolutely crucial in someone with dementia. It's really important that we continue to acknowledge that someone's autonomy, but recognize their vulnerability as well. And having dementia does not automatically mean they do not have capacity. And so I do this a lot in the clinic with patients and their families by talking about what matters to them, and that what matters to them might change over the course of their illness and changes in their social situation. So it's important to revisit this and help family members understand your role as their support person, but also as their medical decision maker and enduring power of attorney as well. But the earlier the better, and revisit this during critical points, especially during illness episodes and care transitions. And people often ask, how do I know what's more about a person with dementia? And we can ask a few questions of families and caregivers. And this is some of the questions that I might provide examples. And this is work taken from Barbara Hayes that some of you might be familiar with as well. But it's also important to acknowledge that families often respond emotionally rather than cognitively. And when emotions are high, people don't quite make rational decisions, and that's true for us as well. And we do need to acknowledge the emotional journey that people go through and support them, and reminding them about that decisions made on someone's behalf is not about imposing their notion of quality of life on the person, but what that person would have made for themselves if they were able to. So it's not about best interests, but about someone making decisions about what they want if they were able to make it for themselves. These are some of the tools that are used in supporting decision making. And this is another tool that resource that you can find on the Palliative Care Victoria website called the Dignified and Respectful Decisions Project. So I'm going to close by talking about integrating palliative care and dementia care, which is really about bringing the best of both worlds, and that's about dementia care and palliative care. And it's really such a encouraging sight to see all these organizations in this room together today to think about how we can collectively collaborate, integrate in this space. And it's a multidisciplinary team sport about supporting and caring for someone with dementia. And I want to acknowledge Eliza Campbell's work in terms of thinking about how we can do better in terms of models of care for dementia, which are all these elements that I've highlighted throughout today's talk, and that it needs to be proactive, and to think about how we can help people navigate the journey as efficiently and as more streamlined as possible. So I want to close by saying, coming back to the story that David wrote in the New England Journal of Medicine, Ingrid died in our darkened bedroom on a cold January evening. My name was the last word she said. In a moment of grace, she gazed at me with a look of love that I thought had long since been extinguished forever. It is a memory that will always sustain me. I've since discovered that serious illness doesn't always conclude when the patient dies. It can persist in the survivors, especially the caregivers. I have developed my own set of symptoms that eerily mirrors Ingrid's. I regularly leave things in hotel rooms, I instim it by online bill paying, and I allow stacks of unopened mail to accumulate on the dining room table. I don't think these problems signify cognitive decline. They merely reflect the way that grief unsettles my mind. Still, while sorrows remains, I have many good moments. I'm especially happy when I recall the joy of our marriage and see Ingrid in the faces of our children and grandchildren. There's a lot of Ingrid in me now. I wish there were more, for whatever the future may hold. A goodbye I've come to see is not just the end of life, it's also the beginning of another. And I want to conclude by saying that people with dementia deserve better. They deserve equitable access to palliative care and the benefits it can offer. And we do need better models of care to support the integration of palliative care and dementia care. Because if we make palliative care better for dementia, with people with dementia, we make it better for everyone. In the words of Cicely Saunders, the founder of modern palliative care, she said famously, "You matter because you are you, and you matter until the end of your life." So with that, I'd like to close and thank you for your attention.